So good morning again. One of the areas related to nutrition of low birth weight infants and babies in the neonatal intensive care unit have to do with human milk. And, oh, there we go. Okay. So this slide sort of depicts some of the dogmas that we have in neonatal intensive care and also overall with breastfeeding. If we breastfeed a baby, it's considered that that baby will grow up to be very smart. And if the baby is not breastfed, the dogma is that the baby is not going to grow up to be smart. These dogmas actually are sometimes a little bit overdone, where we sometimes have mothers that are feeling very guilty that they are not able to actually provide milk for their babies. We also have this new concept that we have to provide donor milk or breast milk for all premature babies, and I'm going to talk about that a little bit as we go on here. So the agenda for the next 30 or so minutes, I'm going to give you a little bit of a background on nutritional needs, and actually I've done most of that in my previous lecture. I want to talk about human milk for preterm infants. Is it really special, and does it meet the needs of the preterm baby in the neonatal ICU? And talk about donor milk, mother's own milk, and formulas, how they compare in terms of benefits for the preterm infant, and then looking forward. So just to reiterate some of the things that we talked about before, we want to start amino acid and lipid infusions early in the preterm infants and try to provide a quantity that is similar to what the baby would be getting in utero. And also initiate enteral feedings as soon as possible after birth, preferably on day 0. The way to go, for the most part, is to provide baby's own mother's milk or donor milk if mother's own milk is not available, and then advance enteral feedings, so to reach full feedings, ideally, by days 7 to 10. But I think we need to have some caveats and some considerations for enteral nutrition in preterm infants. Not all preterm infants in the neonatal ICU are the same. Not all mothers of infants in the neonatal ICU are the same. Not all human milk is the same. And the nutritional needs of preterm infants differ at different stages of development. So a 500-gram extremely low birth weight infant is not the same as a 1,500-gram very low birth weight infant. As far as human milk for low birth weight infants, is this always baby friendly? The composition of human milk, is it really special? Donor milk and formulas, how do they compare to mother's own milk? And I want to talk a little bit about the interaction of human milk components with the infant's intestinal immune system. So let's start with the American Academy of Pediatrics guidelines from 2012. And I want to quote, "The potent benefits of human milk are such that all preterm infants should receive human milk. Mother's own milk, fresh or frozen, should be the primary diet, and it should be fortified appropriately for the infant born weighing less than 1.5 kilogram. If the mother's own milk is unavailable, despite significant lactation support, pasteurized donor milk should be used. Quality control of pasteurized donor milk is important and should be monitored." Those are the guidelines. So let's start with some questions. Number 1, the average protein content of term donor milk is A, the same as preterm baby's own mother's milk, adequate for optimal growth of the extremely low birth weight infant, approximately 2.2 grams per deciliter, approximately 0.9 grams per deciliter. What is the right answer? Anybody want to? C? Okay, let's talk about this, okay? Composition. So here we have several different studies. And here is preterm human milk, okay? And if a baby is born at less than 29 weeks gestation, the composition of that human milk protein is 2.2. If the baby is born a little bit later, the composition is 1.9 grams of protein. However, what do we usually give to preterm babies when we give them donor human milk, banked donor human milk? It usually comes from mothers who have been breastfeeding their babies for over 6 months. And they provide whatever is left over after their babies are being fed. So the actual composition of banked donor milk in terms of protein is 0.9 grams per deciliter. That's not a lot of protein. So this just shows something very similar, the protein concentrations in human milk in very preterm babies versus term babies. So the term babies have lower protein concentration. The term babies' mothers have lower protein concentration. What is the protein requirement? Well, the estimated protein requirement for a very low birth weight baby is around 3.5 grams per kilogram per day. That's what the fetus is getting in utero. So if we extrapolate to what I just showed you, if you're giving a concentration of 0.9 grams per 100 deciliter human milk, that baby would need 330 milliliters per kilogram per day of term donor milk to meet this requirement. That's a lot of fluid for a baby like this, and most babies cannot tolerate that level of fluid. We also know that preterm babies grow better with protein supplementation. These are studies that were done by Embleton and Cook, and here we have 3 different formulations. These are isocaloric with higher protein content, 3.3 versus 3 versus 2.7. And those babies that are receiving 3.3 grams per 100 kilocalories grow considerably better than the babies who are receiving the 3 or the 2.7. So more protein, better growth. What about head circumference? These are older studies looking at formula versus donor breast milk. And here we're seeing that the donor breast milk is not as good as the formula in terms of head circumference growth. But remember, these are unsupplemented donor milks, okay? These are unfortified donor milks. So this is a problem if you have unfortified donor milk, that you are actually having a head circumference growth that is not even as good as with formula. What do we see here? Baby with a fracture, okay? About a little bit over a month ago, I was making rounds in the neonatal ICU, and we had a baby who was transferred to us from another hospital, and that baby had been on steroids, on high levels of furosemide, and was getting TPN without very much calcium and phosphorus. Both of that baby's femurs were fractured. Baby had broken ribs and also had a broken humerus. Numerous fractures. This is very difficult when we have this to have to tell a baby, a baby's parents, we broke your baby's bones. So with human donor milk, we have some real problems in terms of the amount of calcium and phosphorus. Here are the requirements, relatively high. Here is human milk, low. And here is fortified human milk, and here's preterm formulas. So we are not providing very much calcium and phosphorus in unfortified donor milk. This is a potential problem. So why do we fortify? Human milk has many benefits, but it doesn't have all the vitamins and minerals and calcium and phosphorus and protein that is required for growth and neurodevelopment. Very important reasons to try to fortify human milk. We have developed guidelines and a protocol to fortify breast milk, and this is just our particular protocol. There are different variations of this, but this is what we use in terms of fortification of preterm or donor milk or baby's own mother's milk. One of the problems with fortification is that you can actually reach osmolalities that are fairly high. The AAP recommendation is 400 milliosmoles per kilogram of water. Adding 3 or 4 of the following to human milk plus fortifier may markedly increase the osmolality to near or over 1,000 milliosmoles per kilogram of water. So if you add, just these, 3 of these, multivitamins, dexamethasone, caffeine, chlorothiazide, etc., you will increase the osmolality to over 1,000. This is considered to be potentially dangerous to the gastrointestinal tract of preterm babies. Another question. Pasteurized donor milk compared to fresh mother's milk has less lipase activity, has few, if any, live cells, has minimal live microbes, is largely devoid of CMV. All the above. What's the correct answer? All the above, right? Okay. Well, let's look at this a little bit more closely. This is a slide that I was able to get from a colleague from a University of Western Australia, Peter Hartman and his group. And they have done a lot of studies on pasteurized milk versus baby's own mother's milk. And here are some of the components of donor milk after Holder pasteurization. Now, what is Holder pasteurization? Holder pasteurization involves 1/2 hour of exposure to a temperature of 62.5 degrees centigrade, okay? And that's essentially cooking the milk for a short period of time. So here are some of the changes that we have in milk after Holder pasteurization. I want to just point out some of these. Alkaline phosphatase is decreased by 99%. Bile salt stimulated lipase is abolished. Lactoferrin, slight decrease. Iron binding capacity, decreased. So a lot of things are actually decreased if you pasteurize mother's own milk. So what are the implications of abolishing some of these activities? So what is BSSL, or bile salt stimulated lipase? Well, we have several lipases in our bodies, and babies have the same lipases in their bodies. And what do lipases do? Lipases take the triglyceride molecule and split them into monoglycerides and glycerol, okay? And then the monoglycerides and glycerol can then be taken up into the gastrointestinal epithelium and utilized for various purposes. If you don't have lipase present, this process does not occur, and the absorption ends up being very inefficient. We have several different kinds of lipases. We have lingual lipase, produced at the base of the tongue. We have gastric lipase, which is produced in the stomach. And then we have pancreatic lipases, which are produced in the pancreas. A premature baby does not produce very much pancreatic lipase. It takes a couple of months for that pancreatic lipase to be adequately produced. Human milk, not formula, and don't pasteurize donor milk, contains lipase, bile salt stimulated lipase. And this is a problem if you pasteurize. As I said before, this is totally abolished with the pasteurization process. There's actually some studies, this is a study from Italy, looking at giving recombinant lipase, recombinant bile salt stimulated lipase to premature babies to make up for the pasteurization process in donor milk. What about alkaline phosphatase? This is another important enzyme. Premature babies have very low levels of alkaline phosphatase in their gastrointestinal tract. However, human milk is very rich in alkaline phosphatase. What does alkaline phosphatase do? Well, here it shows that the alkaline phosphatase is involved in actually breaking down some of the components of gram-negative lipopolysaccharide. In other words, it inactivates some of the very important components of bacteria that cause an inflammatory response. So having alkaline phosphatase is an important component of the innate immune system for these babies. Breast milk also contains stem cells. And if you provide baby's own mother's milk that is not frozen, these stem cells are alive. If you provide pasteurized milk or frozen milk, these stem cells die. We're beginning to recognize that these stem cells may have an important process. If you take human milk stem cells and put them into a fresh newborn mouse, those stem cells will actually proliferate in that newborn mouse, and they will differentiate into various kinds of cells, such as pancreatic cells. And even in the brain, you find some of these stem cells in adulthood. So we're just beginning to recognize that these stem cells may play an important role. And if you pasteurize the milk or if you freeze the milk, these stem cells are gone. What about microbes in human milk? In the past, if we were able to find microbes in milk, we would throw it away. We were afraid of microbes in human milk. But now we're beginning to recognize that microbes are actually present in human milk, in fresh human milk, and that they may actually play a role. This is a study that was done at University of Idaho just a few years ago, and this is using non-culture-based techniques, 16S sequencing techniques, to look at microbes in human milk. And here we have human milk from 16 different mothers. Each one of these S's represents a different mother. And these samples are at 1 week, 2 weeks, and 4 weeks. And each color represents a different family of microbes. What we see is very interesting. In this particular mother, the microbes at 1, 2, and 4 weeks look very similar. In this mother, at 1, 2, and 4 weeks, they look very similar. But this mother, compared to that mother, is very different in terms of her microbes. All of these mothers have different sets of microbes, but over time, they are very similar within each mother. This suggests a personalization of microbes. We have not yet studied this to any extent, but it suggests a personalization of microbes coming from the breast milk. Studies done in our laboratories, we've been able to grow many of these microbes from human milk. These microbes are not skin microbes for the most part. They are their own very separate type of microbial ecology. Next question. Donor milk prevents necrotizing enterocolitis. True? False? Or maybe? I hear a lot of truths. Okay. Well, let's look at this a little bit more closely. Here is a baby with classic necrotizing enterocolitis, distended abdomen, erythema of the umbilicus, and this baby received an X-ray. Here you can see pneumatosis intestinalis, portal venous gas. That baby continued to do worse, and the baby was taken to surgery, and this piece of bowel had to be removed. Okay, that's necrotizing enterocolitis, major problem, and we'd really like to be able to prevent this. Studies done in the late 1980s, 1990, showed that human milk can be very protective against necrotizing enterocolitis. This is a classic study by Alan Lucas and colleagues showing that if you give formula alone, the incidence of necrotizing enterocolitis is 7.2%, and if you give human milk alone, it's 1.2%. But this was done before the era of actually providing fortification to the human milk. And the amount of donor milk here, most of these babies were receiving the baby's own mother's milk rather than donor milk. What about donor milk versus formula? This is a meta-analysis of necrotizing enterocolitis with donor milk versus formula. And here you can see that it actually seems to favor donor milk. You have less necrotizing enterocolitis if you provide donor milk. So those of you who said true, this would support that, wouldn't it? Okay? But let's look at this a little bit more carefully. Some of these studies were older studies done in the 1980s, 1990s. And when you think about the definition of necrotizing enterocolitis, some of these studies did not clearly define necrotizing enterocolitis. They also included something called stage 1 necrotizing enterocolitis, which we don't even know what that is. So I think we have to consider some of these studies as being somewhat suspect in terms of preventing necrotizing enterocolitis. This is the only, prior to a couple of very recent studies, this is one of the largest studies done looking at donor milk, preterm formula versus mother's own milk. This is Richard Chandler's study. And here we see in this Chandler study that there really is no difference in necrotizing enterocolitis. It comes out to be a nonspecific p-value, 0.27. If you give donor milk versus mother's own milk versus formula. This is the largest study done thus far using those three comparisons. But then when you look at some of the demographics here, social characteristics of those three groups, those babies who received their own mother's milk, not donor milk or formula, those mothers were of a higher socioeconomic status, had higher educational levels, were in the neonatal ICU a lot more than those babies whose mothers received donor milk or received formula. Again, suggesting perhaps a confounding factor for that trend that you saw with decreased necrotizing enterocolitis, even though it was statistically non-significant. So as far as donor milk and necrotizing enterocolitis, most cited references that suggest a protective effect are in the meta-analyses that I showed you. Most of the studies in the meta-analysis were conducted before cow's milk fortifier use. The Chandler study did not show significant difference. P-value was 0.27 in donor milk versus formula. Thus, extrapolations of currently used fortified pasteurized donor milk to formula in the prevention of NEC are problematic. Now we have a couple of studies where exclusive human milk was being fed to babies. And by this I mean, rather than using cow's milk fortifier, human milk fortifier was used. Some of you may be familiar with the term Prolacta. This is the brand name for a humanized fortifier. The first study was the Sullivan study. And this was an unblinded trial comparing bovine fortifier to exclusive human milk fortifier. And in this study, the bovine group experienced a higher incidence of necrotizing enterocolitis. Another study, the Christofello study, was a follow-up to this. And this was a blinded randomized trial of exclusive human milk versus preterm formula. And there was a trend toward decreased necrotizing enterocolitis. Not statistically significant, but the baseline rates were exceedingly high, 19% necrotizing enterocolitis baseline rates. The post hoc analysis of both groups suggested increased NEC in the bovine supplemented human milk and formula groups, but because of the small sample sizes, these were not powered to look at necrotizing enterocolitis. They were small sample sizes and high NEC rates. In the formula group, it was twice the previous studies, and these results need to be interpreted with caution. Very recent study in California, and again, this is not a randomized study, but they looked at before and after they introduced donor milk in different neonatal ICUs in the state of California. And here we see NEC rates consistently seem to decrease. But again, this is looking at historical controls. So this is not a randomized study. Very recently, there was a randomized study done in the Netherlands, and this is from Hans van Goederver's group. And the title of this study was Effective Donor Milk on Severe Infections and Mortality in Very Low Birth Weight Infants. This is a slide that Hans van Goederver lent to me, and here's the design of this study. On day one, they started the intervention, own mother's milk plus donor milk or own mother's milk plus formula, okay? And when available, own mother's milk plus formula, otherwise formula feeding from day 10 to day 60. Then they looked at the outcomes in these babies. What did they find? Well, here is the characteristics of the patients, the demographics, no difference in the two groups. But when they looked at sepsis, necrotizing enterocolitis, or death, no difference between the donor milk group versus the formula group. But again, this is only with 10 days of comparison. So I'd like to stop here with some take-home messages. Not all human milk is the same. There may be disadvantages to using only donor milk in terms of growth. Baby's own mother's milk appears to have many advantages over donor milk, including microbes and microbial metabolites, enzymes, and live immune cells. The future goal is going to be to safely provide fresh mother's own milk, or the multiple components found in fresh baby's own mother's milk. Thank you for your attention.